Yes.
Sir,
Yeah. Can you hear me?
Yes.
Yeah.
Thank you. Thank you very much. Thank you, Dr. Namrata, and then Dr. Bansal, sir. And also thank Alargan for organizing this meeting. Today, I'll be speaking on the intraoperative floppy iris syndrome and associated with the alpha blockers. No financial interest disclosures to make. So, the floppy iris syndrome was in the sense when we started the Phaco emulsification, that time it was not recognized or described. So way back in 2006, when we were operating, this is the kind of a situation we used to face. If you see the iris started coming out of the wounds, and also when we are doing the Phaco, there was a tremulousness of the iris. Then in this case, you can see the iris floppy, and then the pupil is gradually coming down as the surgery progresses. And the moment you come out and then inject any viscoelastic, the first thing to come out is the iris. So this is the situation at that time. We were not aware about this situation, and then we were thinking why it is happening and all. Then this is another case where the iris initially when we started this case was started, the pupil was nicely dilated, and we were not aware about this the alpha blockers and then the prostatic problem using this drug. So we were not at all asking the patients about this, and this has all become an intraoperative surprise. The main difficulty here is the first thing to come into the Phaco wound is the iris rather than any other structure. You can see how the iris was damaged here. So somehow, luckily, I could escape without much damage in this case. Then we went back to the literature and we have seen why it is happening. And then it was described way back in 2005. And they also noticed a strong association between the Flomex. Flomex, it was the first introduced drug, that is tamsulosin, and then the benign prostatic hypertrophy and the floppy iris syndrome. It is not only limited to the BPH and then the Flomex. It can happen even in the females, and when they are using the alpha blockers for the antihypertensives. And even without that, all the ocular conditions where there is a chronic small pupil and then atrophic iris, like pseudoexfoliation, chronic pilocarpine therapy can also have this kind of a floppy iris syndrome. And it is already proved that the surgical complication rate is higher in the floppy iris. So then we went back to the basics. The iris anatomy, you all know the dilator muscle and then the sphincter pupillae. Dilator muscle is innervated by the sympathetic system, and then where the sympathetic system acts through a receptors. This is the alpha-1 receptor, the alpha receptors. These alpha receptors are again classified into alpha-1 and then alpha-2. So whereas our interest is mainly in the alpha-1, alpha-2 is the presynaptic nerve endings it acts, whereas in alpha-1, it is situated in the dilator muscle. In addition to the dilator muscle, the same smooth muscle alpha receptors are also situated in the pylorus of the duodenum and also the prostatic and then the smooth muscles around the ureter. So actually, we are the unfortunate victims of the somebody else therapy. When they are treating the urinary problem, we were the victims for that. So it's our responsibility now to educate them. So again, in the alpha, there are two types, alpha 1A and then alpha 1B. So alpha 1A is the subtypes. So they acts on the muscle, whereas alpha 1B acts on the vascular system. So why it is important means there are drugs, they classified the alpha adrenergic blockers into a non-selective and selective blockers. Again, in the selective category, there are alpha 1, alpha 2, and then in the alpha 1, again alpha 1A and alpha 1B. There are subtypes are there. So the drug which is more acting against the alpha 1B, which is the situated in the muscle, is the most the culprit. So tamsulosin, why there is a strong association is the tamsulosin is the drug which directly acts on the alpha 1A. So to summarize this alpha receptor blocking agents, alpha 1A, the adrenergic receptors mediates iris dilator, smooth muscle and contraction. Alpha 1B mediates the iris anterior contraction. So alpha 2 acts at the presynaptic level, so which may not be of much influence on us. So their drugs are again selective blockers like alpha 1 and alpha 2, and subtypes is alpha 1A. So finally, just remember about the alpha 1 and then alpha 1A. So this is the main the drug, whichever drug acts on this agent, on this receptor, will be worst affected. So these are the top types. So tamsulosin is mainly acts on alpha 1A. The other drugs, nowadays there are many drugs so the urologists are using, like the terazosin and then doxazosin, then aflozosin. But the most the dangerous drugs for the ocular point of view is the tamsulosin and aflozosin. These two are the drugs. The main advantage of these drugs for the urologist point of view is they act mainly on the smooth muscle without much effect on the systemic postural hypotension. So that is the reason why the side effects are less and they get the maximum effect on their point of interest. So that is the reason why they were using that. But unfortunately, these are the two drugs will have a maximum effect on the dilator muscle. And when we search this literature, what is the current pattern of their treatment in the systemic point of view? Urologists, they like an alpha blockers. They become a first choice of treatment in the benign prostatic hyperplasia. Even in the women with the hypertension, also some of the physicians preferring the alpha blockers. And if there is a combination of the BPH and then the hypertension, some of the physicians are choosing the alpha blockers. And there is also not only is limited to the males, in the females urinary tract symptoms also, there are studies which they are using the alpha blockers. So finally, I can say in future, this is become inevitable, we cannot avoid this, and the numbers are bound to go into increase. Coming to the clinical effects, how can we recognize this? Yes, we can recognize in the preoperatively when we are very sensitive about this. What people, size of the people is the best indicator whether the drug has already have an effect on the dilator muscle or not. If the pupil is purely dilated only on the alpha blocker, definitely we can say this case is going to have a difficulty during the surgery. And during the surgery, the iris billowing and then prolapse and progressive intraoperative meiosis is an indication. And the worst thing is already who are using on that, especially tamsulosin, 90% of those patients will definitely have some form of an IFIS. And the worse than that is even if you discontinue the drug, still that effect is going to last. And even if they have used it several years back also, still we will have an IFIS. So now coming to the strategy. So we cannot avoid this. Coming to our strategy is we should include this in our preoperative checklist. And then in the clinical examination also, we should anticipate, plan, and then prepare the patient accordingly. Then it is no more a routine surgery. We have to prepare the patient under the visual prognosis. When it comes to the surgical steps, the wound construction should be of more corneal. The tunnel length should be more so that the iris will not come out very easily. And we should try to complete the surgery with a smaller wound with a one entry instead of going frequently into the AC and then coming out. And then during the chamber, try to stay away from the iris. And then we can use a pharmacological agents like tropicamide, phenylephrine, lignocaine combinations nowadays are intracamerally available. We can use that. In a moderate cases, we can get away with that. In worst cases, the best thing is to use a pupil expander. Let me show some of the cases. This is this is the combination drug which I generally use. Here, in this case, the pupil was reasonably dilated with a history of the alpha blocker usage. We should use intracameral the combination drugs of the dilators. And then if you see, even in spite of that, the people, by the time we are reaching that, it's almost coming down. So with the pharmacological agents, you can see the floppiness of the iris. Now you can see how the iris is fluttering. So pharmacologically, in a moderate or mild cases, we can complete. Coming to the another case, this case is again a small pupil with the with the effect of the alpha blocker, but here the nucleus is very hard. In these cases, we can try with our earlier strategies like staying in the center, avoiding long tunnel, and keeping the chamber deep. With the pharmacological agents, we can complete the surgery successfully sometimes, but one should not hesitate to using the pupil expanders. Coming to this case, so we can see definitely the pupil is on a lower side. So one should not hesitate to use the rings, expanders. Again, coming to the expanders and then the retractors, in this case, expanders will be a better choice. Coming to the expanders, I would prefer a slightly bulkier a Gupta ring or the ring than the BHEX. BHEX is little delicate, and then the pupillary dilatation also. Here the main idea is we should stretch and keep the pupil try to be away, and then keep the diaphragms still lower than the wound level. So in this case, a expander like this will be a better choice, and then we can complete it successfully with that. Then at the end, you can see how the pupil was lax. I could complete it, and in spite of the very small pupil. So pupil expander is a better choice. So to summarize, we will see more and more of these kind of cases in future. Preoperative planning, including the checklist regarding the usage of drugs, clinical examination, and then keeping them on a guarded prognosis, like wound, whatever we discussed, the wound architecture change, and then our maneuvers, and then other things. The another most important thing is we should start educating the urologist about this problem, and then that is the only way I think in future. Thank you very much.
Thank you so much, Dr. Gopal Raju.